Let's start with cell and tissue pathology, namely parenchymal degeneration. The injured cells and tissue exhibit changes in their microscopic appearance. Grossly, sick organ may change too. These morphological alterations described by term dystrophy or degeneration. In English books, textbooks of pathology, you find the chapter of cell injury, cell degeneration, and cell accumulation. There are few mechanisms of dystrophies. Infiltration is the first mechanism, then goes decomposition, transformation, and pathological synthesis. You must remember all these four mechanisms. Let's start with infiltration. So we call it infiltration when something unusual has been brought and added to the cells of our intercellular space. Here you see lipids between myocardial cells. So in that case, we call it infiltration. Decomposition is a deformation of the plasma membrane with disintegration of lipoprotein complexes and sequel accumulation both lipids and proteins within the cell. So here you see the sample, tissue sample of myocardium. This tissue sample stained with Sudan 3, and so under number 1 we see the accumulations of lipids within the myocardial cells. Number 2, you see the piece of myocardial tissue without lipids accumulations. Transformation is a stockpiling of a product made from the common primary substance. For example, here you see the picture of the kidney tissue. You see tubules with so pinkish reddish accumulations of glycogen. And pathological synthesis. It is a product of abnormal metabolism. So, for example, here we see the amyloidosis. Number 1, we see the accumulations of amyloid, which is a result of pathological synthesis, because in normal situation we can't see in human body amyloid. According to the type of substance, we can see protein, fatty, carbohydrates, minerals, and pigment accumulations. Let's start with intracellular accumulations in more details. Proteins dystrophy. We recognize hyaline dystrophy, hydropic vacuolation, or vacuolar dystrophy. And what is it, hyaline dystrophy? It is caused by coagulation and denaturation of protein, which gives cell cytoplasm a homogeneous glassy appearance. Under microscope, we see that tissue architecture is maintained, but the cells are larger than normal, with recognized presence of structures, proteinous material called hyaline. Protein hyaline drops in the epithelium of the proximal convoluted tubule of the kidney. Here you see in this picture. In the cytoplasm of the convoluted tubule epithelium, we see a large hyaline-like droplets here under number 1. They stand with pink erosion quite nicely visible. Epithelial cells are enlarged in volume, their borders are fuzzy, the gaps of the tubules are narrowed, protein precipitates are found in them. Here you see the electron microscopic picture, and we see that protein helianthropes within the epithelial cells. Here we see the convoluted tubule of the kidney, and within the epithelial cells there are numerous hyaline droplets. Number 1 shows these areas. They are represented by accumulations of loose matter of low electronic density. Other picture, but again we see here the droplets in the renal tubular epithelium as a result of reabsorption from the. It is seen also in the liver cells of alcoholic, we call them Mallory's bodies, and in striated muscle, rectus abdominis. In case of severe infections such as typhoid fever, we call it Zenker's degeneration leading to necrosis. Also, the hyaline dystrophy is irreversible, you must know that. And as a result of this hyaline dystrophy, we may see the cell necrosis. This is a type of coagulative necrosis. Here we see the sample of liver tissue of alcoholic, and as a result of alcoholic abuse, we see the cluster of inflammatory cells, and also we see the necrotic hepatocytes, some other necrotic hepatocytes. Here we see, and Mallory body shows the changes within the hepatocytes as a result of coagulative necrosis. Hydropic vacuolation. This type of dystrophy may be produced by anoxia, infections, or poisons. We see cell swelling and hydropic vacuolation caused by any agent that alters the ionic content and water balance of the cell. Cell swelling is seen at parenchymal cells of liver, kidney, and heart. Grossly, sometimes we can't see anything, but under microscope, at the beginning one can see the boundaries of the swollen cell becomes less distinct and the cytoplasm more opaque and granular. Here we see the tissue sample of kidney under microscope under high magnification, and we see the hydropic dystrophy of the epithelium of the proximal convoluted tubule of the kidney. We see swelling and vacuolization of the cytoplasm of the epithelial cells of the proximal convoluted tubules. Here we see number 1 shows that. By the way, you can compare with the other epithelial cells on the right of this picture. So you see that they are not so swollen as here in the center and on the top left. So here you see some areas, transparent areas within the cells. Some foci are without nucleus, so we can imagine that here there is necrosis area of epithelial cells. So nuclei are displaced to the basement membrane of cells. We see pale staining of these cells. The lumen of the tubules is narrowed. Peeling of the epithelium in some areas is noted. Here we see the electron microscopy of the cytoplasm of hepatocytes with severe dystrophy, hydropic dystrophy, in a way of balloon, so-called balloon dystrophy. So we see multiple tanks of cylinders filled with liquid. The membranes of the endoplasmic reticulum in their areas are destroyed. Severe injuries to the plasma membrane and cell organelles are usually lethal to cells and resulted in colliquative necrosis. Let's go to lipids. Parenchymal dystrophy, which caused by lipids metabolism disturbances. You remember that lipids exist in cell in the form of lipoproteins. These lipoproteins contain protein, phospholipid, cholesterol and its esters, and 3 glycerides. There are various causes of such pathology, various infections, chemical poisons, disorders connected with tissue hypoxia, anemia, cardiac failure, respiratory diseases, nutritional causes due to protein and choline deficiency, and, for example, toxemia of pregnancy. Here on this picture on the left, we see normal cell, and on the right, we see the cell with the lipid accumulation within the cytoplasm in case of fatty liver. Grossly or macroscopic picture of the fatty change of the liver is one of yellowish pallor and swelling of the organ. So we see liver enlarged, the edges are rounded and bulge outwards from the capsule. And this appearance referred to as the goose's liver. Under microscope, here we see the high power detail of fatty change of the liver, that in most cells, the well-preserved nucleus is squeezed into the displaced stream of cytoplasm about the fat vacuole. So here you see a lot of vacuoles. This is also a picture of liver tissue, but stained with Sudan 3. So we see a lot of vacuoles of different size, but orange color. Due to special staining for fats, it is Sudan 3. Let's go back. Here you see some stripes, darker brown and lighter yellow. Fatty degeneration of myocardium stained with Sudan 3. Here in this picture again, we see in the cytoplasm of muscle cells located mainly around venules and veins. We see clusters of small drops of yellow-red fat. Number 1 shows that. Other muscle cells are free of fatty inclusions. Here, this area under number 2, there is no transverse striation of muscle cells. The core is wrinkled or lysed. Here, electronic microscopic picture, we see fatty degeneration of the myocardium. And with electron microscopy, the cytoplasm of cardiomyocytes is filled with small drops of fat. Mitochondria are destroyed. Here you see these drops of fat, And look here, the mitochondria with various sides of destruction. Less destruction and more severe destruction of the mitochondria. Here we see also areas of destruction of the structures of the cell. Look here, the liver with steatosis. We see the surface of affected liver which becomes irregular with progression of fibrosis. At the end stage, we may see cirrhosis or even hepatocellular carcinoma with a background of cirrhosis. The kidney, in case of steatosis or fatty disease of kidney, the organ also enlarged and pale. Here, the tissue sample of the liver in case of fatty liver disease. We see under microscope clear vacuoles consist of fats which are recognized within hepatocytes. Now we go to carbohydrates. The example is a disease known as diabetes mellitus. This pathology is associated with lack of insulin, resulting in stimulation of breakdown of glycogen to glucose and increased plasma glucose. We call this hyperglycemia. Causes of diabetes mellitus are various. Pancreatic causes following the destruction of the islands of Langerhans. They may be adrenal due to overproduction of glucocorticoids which oppose the action of insulin. Pituitary associated with an overproduction of growth hormone or insulin antagonism in the plasma. Here you see the microscopic picture of such kidney. I have already shown you this picture. Look, you see some epithelial cells without any accumulations, and in the center of this picture a lot of epithelial cells of convoluted tubules have accumulations, various sizes, pinkish reddish color. They are glycogen accumulations. Please read yourself more details of such pathology. They are not so common pathology, but anyway you must know them because they may be seen in pediatric pathology clinic. Now we go to intracellular stroma or connective tissue alterations. Connective tissue metabolism disturbances may result in protein, fat, and carbohydrates degeneration or dystrophy. Let's start with proteins. Pathologic changes in protein metabolism are defined as dysproteinosis. There are various kinds of such dysproteinosis. We know mucoid swelling, fibrinoid changes, hyalinosis, and amyloidosis. First three could be stages of the same process, starting with mucoid swelling, going to fibrinoid changes, and at the end, hyalinosis, for example. But amyloidosis is quite special, a type of dystrophy because it is accompanied with the accumulation of amyloid, which is not seen in the normal situation within the human body. Let's start with mucoid swelling. Here you see the picture with special staining. We call it the reaction with metachromacy. We see the toluidine blue staining, and the main color of the stain is blue, but in some areas the color changed to pinkish, and so we call it metachromatic reaction. This reaction is common for mucoid swelling of the tissue. So this type of degeneration is reversible. Elimination of the pathological stimulation of this process can cause full repair of a connective tissue structure. But also, it can go further, and fibrinoid changes could be the next stage after mucoid swelling, and then it may result in fibrinoid necrosis, so the cell injury and cell death. Fibrinoid changes. Such pathology, for example, we can see in collagenous connective tissue and small blood vessels. So here you see the blood vessels, and this pinkish area with no, in some areas with no any nuclei. These changes are example of fibrinoid changes of the vessel. Histochemical and fluorescent antibody staining technique may show the presence of fibrin in fibrinoid. So we can see fibrin and sometimes gamma globulin within the fibrinoid due to special immunofluorescence staining. So in this picture, we see such reaction, which help to detect deposits of fibrin in testicular vessels affected with fibrinoid necrosis. This represents a morphological hallmark of necrotizing vasculitis. The magnification is 200. So please remember that histochemical and fluorescent antibody staining techniques is very important to detect the presence of fibrin, gamma globulin within such lesions. Under microscope, in case of fibrinoid swelling, we see the fibrillary material deposits between surviving collagen fibers. So here we see the wall of the vein with accumulations of fibrinoid in intima and between smooth muscles sites. Here, this is the area of fibrinoid change in the renal arterioles, and it is quite common to malignant hypertension. The presence of fibrin in collagenous fibrous tissue, common feature shared by so-called collagen diseases, fibrinoid changes. Here, this is the area of fibrinoid changes. It's quite common to collagen diseases like rheumatic diseases, including rheumatism, various kinds of vasculitis, and so on. Hyalinosis is a term used in reference to dense amorphous eosinophilic material. Here on the left we see arteriolar hyalinosis, and arrows shows these changes within the vessels wall. These heterogeneous changes have in common only the presence of uniform structureless proteinaceous material called hyalin. Such changes could be seen in hypertensive disease. Hyalin is formed in inert connective tissue like old scars, in blood vessels walls, serous membranes such as pleura, peritoneum. We can see hyalin in capsules of organs, for example, in spleen. Also in layers of arteries, especially large arteries like aorta. Here again the example of hyalinosis. Number one is the area of hyalinosis of the spleens vessel. We see that the lumen of the central artery is sharply narrowed. The walls are significantly thickened due to the deposition in the intima of homogeneous masses of pink color, pushing out and destroying the elastic membrane. The muscle fibers of the middle membrane are atrophic. The number of cells in the lymphoid follicle is reduced. Here we see number 2. And proliferation of connective tissue around the vessel is expressed. Here you see the connective tissue around the vessel. Now we go to amyloidosis. Amyloid is a fibrillary protein which stains pink with Congo red and brown with iridine. We may classify amyloid according to the type of protein fibrils we call AL, AA, AF, and ASC1 amyloids. We may classify due to primary cause, or it may occur in the course of a group of diseases, so-called secondary amyloidosis. Also, we know hereditary and senile forms of amyloidosis. And according to propagation, we classify all amyloids into localized and generalized pathology. How the organs looks like in case of amyloidosis. Here you see the microscopic picture of the liver, and in case of liver amyloidosis, we see the deposition either in the walls of hepatic artery branches or outside the endothelial surface of the sinusoids. So here you see the orange reddish accumulations of amyloid, and to detect such accumulation one must make the Congo red reaction, Congo red staining of the tissue sample. And this orange reddish coloring of the vessel, liver vessel, support the proper diagnosis of the liver amyloidosis. Grossly, liver look looks like here on the left picture. The severely affected liver will be larger and paler than normal, of more firm consistency, and the cut surface will have a waxy appearance. Please remember, the diffuse amyloidosis of various organs like liver, kidney, spleen, doesn't matter which one, they all have a waxy appearance. Here, on the top left, you see the gross picture of the spleen. You must know that amyloid deposits may appear in and grow around the arterioles of the Malpighian corpuscles, with the result that macroscopically the enlarged spleen will present a cut surface studded with a large number of gray semi-translucent dots. So in case of such accumulations, we see so-called saga spleen. But here in such picture, we see diffuse pathology. So the amyloid may form principally in the red pulp, in which case the cut surface of the spleen will be uniformly waxy like the liver we have already seen. So here we see the diffuse accumulation, which make such a white, which help to create such waxy appearance to the spleen. Under microscope, we see the accumulations of amyloid in spleen. Here we see the kidney. On the top left, the picture shows the part of the kidney. Kidney is pale, enlarged, grossly pale, enlarged, and also with waxy appearance of the cut surface. Under microscope, we see the accumulations of amyloid, and the congruent staining helps to detect such accumulations. We see amyloid in kidney within the stroma of the organ. In the vessel's wall, here we see some amyloid accumulations in stroma. They are also orange, brownish, something like that. Then we see in the vessels, and also somewhere here, and on the basal membrane on convoluted tubules. But the main part of the picture on the bottom left, we see these orange accumulations in the basement membrane of the glomeruli capillaries. So various locations of these amyloid accumulations, again in stroma, in basal membrane of the convoluted tubules, within the vessel's wall, and on the basal membrane of the glomerular capillary. So glomerular capillaries, cortex being the affected. Now let's go to stromal vascular or extracellular accumulations, and we go to lipids. Obesity is the example of such pathology. Look here, we see the heart with cardiomyopathy, but also we see here the fat and the epicardium, the fat accumulation. We see the obesity of the heart. So in such case, the patient had congestive heart failure, and cardiac arrhythmia in his medical history, but also please pay attention on obesity. Under microscope, we see here on the right picture the tissue sample of cardiac muscle, and here in this picture we see cardiomyocytes, and between them we see the moderate amount of adipose tissue, and also we see some atrophic changes within cardiomyocytes. So, of course, such person with heart obesity may suffer of cardiac pathology during dystrophic changes, atrophy of the cardiomyocytes. So, they may have various cardiac symptoms. Here we see aortic atherosclerosis, fat spots and strips, atherosclerotic plaques. In the intima of aorta, we see yellow spots and stripes which are visible, swelling whitish gray plaque in the lumen. Some plaques are ulcerated. So everything is accompanied with cholesterol metabolism disturbance. Aortic lipidosis, we see the staining of the aorta tissue by Sudan 3. And in the thickened aortic intima, we see droplets of fat and some crystals which are stained with Sudan in bright yellow-orange color. Now we go to carbohydrates. We see the connective tissue, which may show the accumulation of mucopolysaccharides, other words, glucose aminoglycans. The accumulation of such carbohydrates usually is the result of alteration of glycoprotein's metabolism. In some papers, it is called mucoid or mucinous dystrophy or degeneration. The outcome could be different. For example, in some severe cases, it may result in liquefaction, necrosis, and cyst formation. Here we see such cyst formation. Now we go to mineral metabolism disturbance. First two examples we have already discussed are the results of Dystophies.Calcification. Here you see the other example of dystrophic calcification. We see the piece of the lung sample. Here we see the gross picture of the lung, the section of the lung, and you see a lot of yellowish areas. They are rounded, various size, rounded foci of yellowish grayish color with stony density. So they are Ashov bodies. These are the areas of the tuberculosis with calcification. So during reconvalescence from the disease, these areas of tuberculous inflammation was impregnated by the calcium salts, and we see such stony foci of calcification, dystrophic calcification, as the end stage of tuberculous inflammation. Here we see the metastatic calcification, in myocardium. These violet calcium salts encrust individual cardiomyocytes or group of cardiomyocytes, and we can't see any expressed inflammatory reactions. So here you see cardiomyocyte cells, and here in the center of the picture we see bluish violet color accumulations of the calcium salts. So this may be a result of metastatic calcification. Here we see the metastatic calcification under microscope, electron microscope, with dark black areas of the calcium salts accumulation within mitochondria crystal. Look here, we see again such accumulations in kidney, also calcium metastasis in kidney. So you see dark blue, violet color salts accumulations. You must remember that metastatic calcification commonly detected in lung, kidney, and heart. So deposits of calcium here are found on the basement membranes and in the epithelial cells of the renal tubules. So all these violet bluish areas are accompanied with the calcium salts accumulations. If you're looking down onto the unopened aortic valve in the heart with calcific aortic stenosis, the semilunar cusps are thickened and fibrotic, and behind each cusp are seen irregular masses of piled up dystrophic calcification. So here the salts of calcium accumulated as a result of previous inflammation, and then with time we see dystrophic calcification in the aortic valve of the heart. Now we go to various stones, biliary stones. Here on this picture you can imagine gallbladder with various stones. So concretions within the biliary tract are almost always formed in the gallbladder, and this condition is called cholelithiasis. Gallstones form as a result of solids setting out of solution. Ingredients of bile could be various: cholesterol, bilirubin, and calcium. Depending upon composition and the manner of formation, gallstones are classified as pure, mixed, or combined. The major elements involved in the formation of the gallstones are cholesterol, and they are about 85% of all stones. They are radiolucent. Bile pigment 15% of stones, radiopaque. Calcium, we see in Western cultures most stones are made up of 3 major elements and have a particular high content of cholesterol. Pure pigment stones are usually associated with hemolytic jaundice. Urinary stones in the urinary tract usually form in the renal pelvis or in the urinary bladder. They could be calcium oxalate, is the predominant salt, calcium oxalate. These stones are usually yellow to brown, irregular, and bony hard. Calcium phosphate stones with magnesium and ammonia too. These are usually gray to white, soft, and dry. The causes of the urinary stones formation are injection of the urinary tract, diet, increased function of the parathyroid glands. By the way, all hemoglobinogenic pigments are formed after the breakdown of the erythrocytes, because erythrocytes have hemoglobin as a component of their structure. So, excessive hemosiderin deposition, we call it hemosiderosis, occurs in the tissues in various pathological situations. First of all, hemorrhages. These hemorrhages may cause local hemosiderosis. But other causes like hemolytic anemias, such as sickle cell anemia, for example, pernicious or megaloblastic anemia, chronic passive congestion, multiple blood transfusions, massive oral or parenteral iron therapy may cause the diffuse hemosiderosis. So we see here the general hemosiderosis. We see here the tissue sample of the liver, and the Pearl's reaction helps to detect the hemosiderin, because it has in its structure the iron as a result of the breakdown of the hem, and it is stained with a bluish staining here, and the reaction has the name of Pearl's reaction. So it helps to detect the hemosiderin because of the presence of the iron. Installate endotheliocytes like Kupffer cells, we see such accumulations. Also in hepatocytes, bluish green granules of hemosiderin are visible. This is quite high magnification, and we see this accumulation of bluish pigment diffusely through the whole this tissue sample of the liver. Here it is brownish in case of hematoxylin azine staining, and in Pearl's reaction with Prussian blue reaction, we see this bluish staining, which is specific for iron detection. Primary or endogenous hemochromatosis. It is a rare disturbance of iron pigment metabolism. It is characterized by excessive hemosiderin pigmentation of the skin and viscera, especially the liver and pancreas, associated with fibrosis. The cause of such pathology appears to be an inborn defect in the duodenal mucosa. Absorption of a greatly increased amount of iron results in such pathology. Secondary or exogenous hemochromatosis occurs in cases of chronic refractory anemia, especially in those receiving multiple blood transfusions and prolonged intravenous or oral iron therapy. Hemosiderin pigment is deposited mainly in reticular endothelial cells with a lesser involvement of epithelial cells. Major deposits are in the liver, principally in the Kupffer cells, in spleen, lymph nodes, bone marrow, and adrenal cortex, especially in the zona glomerulosa. Here we see examples of the gross specimen of the liver in case of hemochromatosis. We see dark brown discoloration of the liver. The same we see in the other organs because it is diffuse process. Also, please pay attention to hepatomegaly. And under microscope, we'll find the granular brown-black pigment within periportal in case of milder, or panlobular in case of severe pathology, panlobular hepatocytes accumulations. Now we go to other pigments like hematoidin and bilirubin. Hematoidin and bilirubin are closely related or even identical chemically. These pigments do not contain iron. Electron microscopy has clarified to some extent the exact anatomic pathway of bioformation in the liver. The hepatic sinusoid endothelium forms an incomplete lining separating the sinusoidal blood from the hepatocytes. The endothelium is interrupted by spaces or pores measuring up to 2 microns in diameter. These spaces allow the passage of all blood elements, except the cellular ones, from the sinusoidal lumen to the spaces of descent. There is no basement membrane in the wall, thus the hepatic cells are bathed continually in a fluid with all non-cellular blood constituents. The hepatic cell membranes have numerous fine villous projections which increase their surface contact with this protein-rich fluid. Many small pinocytotic cytoplasmic vesicles are formed beneath the cell membrane bordering on the space of descent, and there is evidence of the imbibition of fluid and fine particles in this region. It is by such an energy-consuming mechanism that bilirubin, unbound from serum albumin, is taken into the hepatocytes. The jaundice symptoms, the mechanisms are following: increased bilirubin load, disturbance in bilirubin transport, disturbance of bilirubin conjunction, disturbance of bilirubin excretion. We classify all jaundices into 3 big groups: prehepatic, hepatic or parenchymatous jaundice, post-hepatic mechanical or obstructive jaundice. So here on the picture of the left of this slide, at the left we see prehepatic or connected with hemolysis or due to hemolysis of the erythrocytes, hepatic due to the liver and gallbladder pathology, and post-hepatic obstructive or surgical during, for example, tumors formation or some surgery which may cause the problem of obstruction of the bile for bile transport. Prehepatic jaundice. In prehepatic jaundice, there is excessive red cells breakdown, which overwhelms the liver's ability to conjugate the bilirubin. This causes an unconjugated hyperbilirubinemia. Any bilirubin that manages to become conjugated will be excreted normally, yet it is the unconjugated bilirubin that remains in bloodstream to cause the jaundice. Here the picture would describe hemolytic jaundice. So, excess production of bilirubin due to excess breakdown of hemoglobin, indirect bilirubin insoluble in water since unconjugated. Such a situation we can see in case of hemolytic anemia, malaria, glucose 6-phosphate dehydrogenase deficiency. So this is the first example, first group of jaundice, which has a name, prehepatic jaundice. Please remember, anemia, hemolytic anemia, malaria, and glucose 6-phosphate dehydrogenase deficiency may cause such prehepatic jaundice. So, as I said before, anemia may be congenital, acquired hemolytic jaundice, sickle cell anemia, erythroblastosis fetalis. All these may cause the breakdown of erythrocytes and prehepatic jaundice. The other group of causes, hemoglobinurias, mismatched transfusions, paroxysmal hemoglobinuria, some diseases with fever, severe infection, for example, fever associated with hemolysis in case of hemolytic septicemia, malaria, especially in black water fever. They all may cause the hemolysis, breakdown of erythrocytes, and prehepatic jaundice, hepatic jaundice. And the third group, post-hepatic jaundice. It may happen due to obstruction of the extrahepatic tree, hepatic or common bile duct. In case on this picture, it is described like the normal bile flow. We see the bilirubin, the substance that causes jaundice, processed in the liver. It leaves the liver and the bile fluid and flows into intestine in normal situation, you know that. You see via the gallbladder, common bile duct, and then goes to intestines. Here you see the pancreas. But in case of jaundice, we see yellowing of the skin of the patient and even eyes. in that case of the mechanical obstructive jaundice, for example, when the bile flow is blocked, in case for the tumor, like for example here you see the pancreatic cancer, so the bile flow blocked, and we see that bilirubin levels increase in blood, and as a result of this increase we see such yellowing of the skin, patient's skin and eyes. So not only the tumor, but the plugging of the lumen by calculi stones, parasites, or various tumors, as I said before, may cause such pathology. Stricture of the lumen due congenital defect. This stricture may be the result of inflammation, or again with neoplastic changes. External compression due to an inflammatory, parasitic, or neoplastic mass. Now we go to other pigment. It has name hematine. Hematine is not a normal breakdown product of hemoglobin. It is a dark bluish or brownish pigment containing iron in the ferric state obtained by oxidation of Hem. You remember that Hem is a part of hemoglobin. So here on the picture at the left, arrows show the intracellular hematine crystal. You see some such crystal within the cell. Malarial pigment is closely related to hematine. It is Prussian blue negative. We see massive amounts of brown pigment found in the reticular endothelial cells of the liver and spleen. So we see very dark coloring of spleen and liver in case of severe course of malaria and patient's death. So it is split by reticular endothelial cell into hemosiderin and bilirubin. Schistosomal pigment is practically identical in composition and distribution to malarial pigment. Another pigment, hematoporphyrins. Hematoporphyrins are iron-free pigments normally present in minute amount in the blood and urine. They appear in higher concentrations in the porphyrias, in which there is excessive formation of uroporphyrins and coproporphyrins. Now we go to melanin metabolism. In case of Addison disease, there is a bronzing of the skin, especially in those areas exposed to sunlight or in those already heavily pigmented. Addison disease is due to the destruction of the adrenal corticals by tuberculosis, cancer, or idiopathic atrophy. By the way, Addison was a doctor of the Guy's Hospital in London, and even nowadays in their museum of the various tissue samples we can see the material collected by this famous doctor. So again, the cause of the Addison disease is the destruction of the adrenals. This destruction may be a result of tuberculosis infection due to various cancers or atrophy of the organ. Other disease states: hemochromatosis with iron pigments, multiple neurofibromatosis fibromatosis, fibrous dysplasia of bone, pregnancy, AKTH-producing neoplasms, and ACTH therapy, tuberculosis, cachexia, and in that case we see patchy hyperpigmentation. Urticaria pigmentosa, lentiga, we see a small dark brown skin spots due to excessive melanin production by an increased number of melanocytes. We see the pigment accumulation in navy. They could be various kind of navy: junctional nevus, compound nevus, intradermal nevus, blue nevus, and melanocarcinoma or melanoma. All these neoplastic changes are accompanied by melanin accumulations. Decreased melanin pigmentation seen in case of albinism, congenital deficiency or absence of melanin, vitiligo or leukoderma. In that case, we see patchy areas of depigmentation. We see such pathology in case of burn or wound scars. And we see some irregular patchy areas of depigmentation. And in case of leprosy, we see also areas of vitiligo, leukoderma, due to nerve involvement. So here you see the example of skin melanosis. This is a sample of the skin from a patient with Addison disease. Look here, under number 1, we see the zone with increased pigmentation. So we see the brown melanin, which is determined in melanocytes of the basal layer of the epidermis, and also some keratinocytes with this pigment in their cytoplasm. In the dermis, melanin is visible in melanophages, the cells that phagocytize the pigment during the death of melanocytes. And this area on the right of the picture under number 2. So here you see the accumulation of pigment, but all of them are a result of the melanocytes' death, and then further phagocytosis by macrophages, and then they can be found here in dermis. Look that epidermis is atrophic. Also, we see the excessive formation of keratin. We call it hyperkeratinosis, which is clearly seen here in this picture. Here, the example of hemosiderosis with ferritin molecules in a hemosiderin granule. Such picture could be seen under microscope. So in an electron microscopic examination, the hemosiderin granule consists of ferritin molecules having a characteristic tetrahedron shape. So this is a picture which describes the hemosiderin granule. Now we go to other pigment, Lipochrome. Lipochrome pigments are yellowish and soluble in fat solvents. Lipochrome pigments in the cytoplasm of hepatocytes, seen here on the picture at the left. Arrow shows this accumulation of yellowish pigment. By the way, when we look at these hepatocytes, we see some atrophic changes within the cells, some of them even with the sign of destruction, of the accumulations of some vacuoles, possibly they are lipids. So we see the degeneration, atrophy of the hepatocytes, and also this process is accompanied by the accumulation of the lipochrome pigments. Here, the example of the pathology which is accompanied of such pigment accumulation. On the left side of the picture, we see the heart with the features of the brown atrophy. So look, the heart is smaller than normal. It has yellowish color, and also if you look at the vessels, they have a lot of curves of such vessels. These vessels are often with the atherosclerotic changes. So here, such heart could be seen in very old patients, with in patients with cachexia, for example, and that is called brown atrophy of the heart. The texture is friable, and as I said before, it is smaller and yellowish in color. Under microscope, we see the tissue sample of such heart. Please pay attention that here we see some accumulations of the pigment which appear at the nuclear poles of the myocardial fibers. They are lipochromes or hemoglobin derivatives. However, they are insoluble in fat solvents. Here they are. And also pay attention that the cardiomyocytes, some of them are atrophic, and we see widened connective tissue between them, and some of them have lost their striated pattern, which is seen in normal cardiomyocytes. So atrophy, and in case of atrophic changes, we see the accumulation of such yellowish brownish pigment at the nuclear poles of cardiomyocytes. And other pigments, ceroid. It is a greenish yellow, acid-fast, fluorescent lipoidal pigment. It is probably a polymer of peroxidase of unsaturated fatty acids. It stains with fat stains, but is not soluble in the lipid solvents. It is seen, for example, in liver, in hepatic cells, in case of experimental cirrhosis, so in various animals due to experimental changes. We can see such pigment in macrophages throughout the body, also in the adrenal cortex, and also we can see it in the ovary. So this is the end of my lecture. I'm very grateful for your attention. So please remember to look at your textbook again and read intracellular, extracellular accumulation, and also the pigment metabolism disturbances for further study of such pathology. Thank you again very much.